All right, I think we'll get started. Thank you everyone for coming to this webinar or this forum of what is Doxy-PEP. Before we begin, I would like to acknowledge that we are all presenting here on the lands of the Kaurna people in Adelaide, and we pay our respects to elders past and present. And we acknowledge that sovereignty was never ceded, and we acknowledge that we are very lucky that we get to work and live on Kaurna land here in South Australia. We will be hearing from a couple of very fantastic speakers today, so I'll introduce you to those in just a moment. But today we're going to talk about Doxy-PEP. Doxy-PEP, of course, is doxycycline post-exposure prophylaxis, which is quite a mouthful. You may have heard about doxycycline as a common antibiotic, but Doxy-PEP is considered to be a tool for the prevention and reduction of syphilis. This session should empower you with some facts that you will need to advocate for your patients and clients, and prescribe the correct medication and prevent the transmission of syphilis. There will understandably be questions throughout. However, we ask that questions be held to the end, where we'll have a designated Q&A time. And I would also like to note that this session is being recorded and will likely be used for health promotional purposes by SAMESH, Thorn Harbour Health, Shine SA, and other sector partners. So today we're going to be talking about Doxy-PEP and what it is. We're going to hear from some really great speakers, starting with Michael Traeger. Michael is an epidemiologist and research fellow at the Burnet Institute in Melbourne with a focus on STI prevention. He is also on the committee for PrEP Access Now. We're also going to hear from Dr. Timothy Bromley. Tim is a sexual health physician who is working with Adelaide Sexual Health Centre and the O'Brien Street Practice and wrote the Carlin Doxy-PEP prescribing guidelines. And finally, we'll hear from Dr. Danae Kent. Danae is a consultant sexual health physician who has worked for 2 decades in sexual health and HIV medicine in both Sydney and Adelaide. Danae is a medical lead in sexual health at Shine SA. She has a special interest in sexually transmissible infections and sexual function in men who had sex with men and trans and gender diverse populations. And she is passionate about prevention, performance, and pleasure. And of course, my name is Skye Bartlett. I am the community legacy lead at SAMESH. And SAMESH, of course, is a partnership between Thorn Harbour Health and Shine SA. And I'll be talking a little bit at the end. So let's jump right into it. And I am going to pass over to Michael, who's going to talk about Doxy-PEP and what the evidence is. Thank you, Michael.
Awesome. Thanks so much, Skye, for the introduction and for the invitation to talk today. So yeah, as Skye said, I'm an epidemiologist from the Burnet Institute. So today my talk is going to focus on a bit of epi, so some trends in syphilis in Australia, then dive into the efficacy data from the clinical trials on Doxy-PEP, give some examples of real-world uptake and early impact on STIs, and then end with some implementation questions for consideration. So next slide, please. So this figure comes straight from the annual surveillance report, and it's the infectious syphilis notification rate from 2014 to 2023. And as I'm sure you all know, syphilis has been increasing. You can see just how much here. So the middle line here is among all people, men and women, and there's been more than a doubling of the infection of the notification rate since 2014. The top line is the notification rate in men. So you can see here by 2023, the notification rate in men is more than 4 times that of women, but still important to note that the trend has been increasing in women over the past 10 or so years. Next slide, thanks. This data comes from the Access Surveillance Network. So Access is a sentinel surveillance network of clinical services, so mostly sexual health clinics across the country, more than 100 clinics. And we did an analysis among gay and bisexual men attending the Access network. So obviously in the notification data, we can stratify by sex, but in our surveillance system in Access, we can look at sexuality and also HIV status and PrEP use. So looking here on the first figure on the left, this is the incidence rate of syphilis from 2012 to 2022. Looking first at the dashed black line, this is among all gay and bisexual men at Access clinics, and you can see again an increasing trend, more than doubling. But what was really interesting when we stratified this by HIV status and PrEP use, you can see that the red line is gay and bisexual men living with HIV, and they have a higher overall incidence rate across the study period. But this blue line is where we saw the greatest increase, and this is people ever prescribed PrEP during the study period. So in this analysis, we found that over the past 10 years, with PrEP implementation and uptake of treatment as prevention, there's been a converging of trends in syphilis incidence between gay and bisexual men with HIV and those using PrEP. And this is likely indicative of a range of things, but probably changes in sexual networks with the introduction of PrEP and U equals U and less zero sorting. The graph on the right just shows incidence trends by age group, and you can see across all age groups, we're seeing a trend, perhaps a slightly greater increase in the younger age groups. Next slide, thanks. So the majority of cases, syphilis cases, I think it's about 60% in the most recent year, are still among gay and bisexual men. However, we are seeing increases in other populations, in heterosexual populations. This data comes from Victoria, and you can see this rather alarmist news article from about 5 years ago about a syphilis epidemic hitting Melbourne. But not only is the epidemic diversifying in terms of populations, but also in terms of geographic spread. So this is from Victoria, but I know there has been similar trends in other jurisdictions observed. If you look here at the bottom right map D, this is gay men, and you can see infections in gay men. And you can see highly concentrated in urban areas around Melbourne. But in the figures B and C, this is notifications among women and heterosexual men, much more dispersed across the state and in outer sort of suburban areas. So a diversifying epidemic in both those senses. Next slide, please. This slide, this figure comes from analysis done by the team at University of Melbourne, and it's genomic analysis. And without going too much into it, the authors wanted to know, is the syphilis epidemic in Australia one epidemic, one outbreak, or is it multiple? And they looked at the strains and the lineages of syphilis cases over the past 10 or so years, and they found that the epidemic is being driven by multiple lineages rather than one distinct outbreak. And what they sort of reported was that they found several distinct transmission networks that were associated with different sexual exposure profiles, with some bridging across the sexual networks. So to give you an example, in this second column here, which is C, sexual risk group, you'll notice that there are men who have sex with men represented across each of these strains. But one of these strains, you can see the fourth one down, is largely representative of heterosexual people. So this data can help tell us something about how interventions in one population may or may not, see benefits across other populations. So if we get syphilis down in one population or in one transmission network, it may not necessarily translate to other transmission networks. Next slide. So I'm sure many of you saw this last month, but the Chief Medical Officer declared syphilis a communicable disease incident of national significance. And just repeating some of the numbers here. So in 2024, the whole year last year, there were just under 6,000 notifications of infectious syphilis, including 10 cases of congenital syphilis. So far this year, so to last month, there's been 3,500, including 11 cases of congenital syphilis. So some really serious increases there. So moving on now to antibiotics for STI prevention. So the concept of using antibiotics to prevent STIs rather than treat is not necessarily a new concept. Anecdotally, can you jump back? Yeah, thanks. Anecdotally, antibiotics have been used to prevent STIs among Australian and US military for some decades. But in terms of the populations we're talking about, gay and bisexual men, this paper was done 15 years ago. This was in a study in 2010 where they asked gay and bisexual men if an antibiotic prevention was available, would you use it? And even back then, more than half said that they were likely to use it. And then there's been a lot of modeling studies done to show that if Doxy-PEP is rolled out, it would have a pretty significant impact on population level STIs. So doxycycline, why doxycycline? You can skip through a few here, Sky. So doxy has been around for a long time, more than 60 years. It's an inexpensive broad spectrum tetracycline, generally well tolerated. It's extensively used for treatment for acne and rosacea for long periods of time in individuals. It's also used as prophylaxis for other infections, so malaria, Lyme disease. We'll probably hear about this in a bit. Some people do experience adverse reactions, but this was a systematic review that was done by the US CDC group a couple of years ago, and they found that while adverse reactions, some people do experience adverse reactions, discontinuation due to adverse reactions is relatively low. So people might experience some of these bad side effects, but quite often it doesn't mean that they need to stop the drug. Next slide, thanks. So doxycycline or Doxy-PEP or PEP for STI prevention. So there was an early pilot study done over 10 years ago now in the US, which was looking at daily Doxy-PEP, which showed some really promising signs of preventative effect of using daily doxycycline, but the study was really underpowered to sort of look at efficacy results. Since then, there's been 4 large randomized controlled trials of Doxy-PEP. 3 have been in people assigned male sex at birth and 1 in people assigned female sex at birth. And there are several ongoing observational studies across different populations. So in terms of these randomized controlled trials, so the efficacy data we have for Doxy-PEP, as I said, there's been 3 in gay and bisexual men and trans women, so people assigned male sex at birth. The first was the IPAGAY study in France. This was among gay and bisexual men using PrEP. The intervention is the one we're familiar with, 200 milligrams of Doxy-PEP within 72 hours. And they found a 70% reduction in chlamydia and a 73% reduction in syphilis. So really strong results. And this study did not find a significant change, a slight change, but not statistically significant in gonorrhea. The next study, almost 5 years later, was the US Doxy-PEP study. This was slightly larger and included people using PrEP and living with HIV. The same intervention, 200 milligrams of Doxy-PEP within 72 hours. And again, significant reductions in chlamydia and syphilis, up to 88%. In this study, this was in the US, they did observe a reduction in gonorrhea, but only about a 50% reduction. And then finally, another study in France by the same group as the first, 546 gay and bisexual men using PrEP. This time they did detect a reduction in gonorrhea similar to the US study, about a 51% reduction. But across the 3 studies, really strong evidence that when taken after sex, Doxy-PEP reduces the incidence of chlamydia and syphilis in this population. So what about cisgender women? So the only large randomized controlled trial has been the Doxy-PEP Kenya study. So this was an open label randomized controlled trial of Doxy-PEP versus standard of care, 450 women in Kenya. There was a high incidence rate of STIs during follow-up, but unfortunately the study authors did not detect any difference between the groups. So they didn't detect an effect of Doxy-PEP. In terms of gonorrhea, all gonorrhea isolates were resistant to tetracycline at baseline, so no surprise there was no effect on gonorrhea. But when they did a little further investigation, they looked at levels of adherence, so that among a subset of people who were supposed to be taking Doxy-PEP, less than a third had doxycycline detected in hair samples. So the authors reported that it's probably due to low levels of adherence, and some qualitative work that they did really identified significant barriers that this population faced in terms of being adherent to Doxy-PEP, within the 72 hours. So side effects, stigma, and privacy issues. So unfortunately, no evidence really from this study. However, the same group just recently in Montreal at the STI World Congress presented the Doxy-DOT study. So this was a pilot study. The intervention in this study was a once-a-week dose of doxycycline. So every 7 days delivered at a study clinic. And the authors, the rationale was that if participants were taking this dose once a week, that would cover them for the 3 days before as a Doxy-PEP dose, and potentially might give them some coverage for the next day or 2 as a PrEP, so a pre-exposure prophylaxis of Doxy. So a small study, only 60 women, but this study did detect a difference. The authors reported a 61% reduction in chlamydia among those taking weekly doxycycline. There weren't enough syphilis cases during follow-up to estimate an efficacy, but again, strong evidence for preventing chlamydia in this population. Thanks, Guy. So what about real-world use? So there are some nice examples coming out of the US, specifically in California. California was one of the first states to really push for Doxy-PEP. The California Health Department put out some guidelines pretty early on. The figures on the left come from analysis looking at notifications in San Francisco, and you can see the blue line here is when the guidelines came out. This is cases among men who have sex with men, and you can see a pretty rapid decline in chlamydia and syphilis cases following the guidelines. On the right was some work that I was involved in, which was again across California. These were PrEP users attending an integrated healthcare system. over 2,000 gay and bisexual men on PrEP who started Doxy-PEP. And again, we saw similar declines in syphilis and chlamydia, 80% and 79%. So similar declines were observed in these real-world data that we saw in the clinical trials. So for gay and bisexual men and transgender women, real-world effectiveness is likely to be similar to the efficacy from clinical trials. What about Australia? So, the implementation of Doxy-PEP hasn't been as rapid as it has been in the US, and we have the consensus statement, which I'm sure we'll talk about. But we looked again in the Access Network over the past 3 years to see if we could see anything happening in terms of syphilis and chlamydia cases among gay and bisexual men. And so this is monthly number of syphilis cases among gay and bisexual men across the network. And if you push forward a couple, Sky, you'll see that these two lines represent, this is the New England Journal paper. So this is when the US Doxy-PEP paper was published. And then a few months later, when we released our ASHM Doxy-PEP statement, and we found that there has been a sort of curve in the trend. And if you push forward again, we estimated, what this relative reduction was due to the Doxy-PEP guidelines. And projecting forward the existing trend, we saw about a 50% reduction in what you would expect if there was no interruption. So perhaps some early evidence or some suggestion that Doxy-PEP is having an impact on syphilis here in Australia. And the next slide, so this is notification data from South Australia. So thanks to Tom Rees for supplying this. And you can see here in 2024, especially among males, there's been a pretty significant drop-off in the number of syphilis notifications in 2024 compared to 2023. So the first time cases have declined since COVID. So again, this may be early signs of Doxy-PEP use, but I think we need to be careful, and perhaps some more investigation is needed to really understand, what's driving these and if it's because of Doxy-PEP. So finally, because I'm a researcher, I'm interested in implementation questions and considerations. We have the Doxy-PEP consensus statement, which includes some prescribing criteria and some guidance for Doxy-PEP eligibility. ASHM is currently developing full clinical guidelines, which will include a lot more information. But the guidelines hopefully will consider how long people should be prescribed Doxy-PEP for, how often Doxy-PEP users should be tested for bacterial STIs, how we can monitor for AMR, and how we can evaluate real-world impacts. And then, of course, we need some further research in how we can best support people to be adherent to this intervention in the real world, considerations around training and education. And then I think it's really good to have these discussions as a community and a sector about how actively we should be promoting Doxy-PEP. Unlike HIV PrEP, where the risk-benefit sort of calculation is pretty clear, is that the case for Doxy-PEP, or should this be a much more sort of individual level of decision? And I think that's all I had. Next slide. That's it. Great. Thanks so much for listening.
Thanks, Michael. That was fantastic. Again, if you do have questions, please hold them off until the end. And next, we will hear from Dr. Tim Bromley.
Thank you. Do you want a quick forward? So I'm going to go through syphilis, and I'm sorry that I'm sure many of you are very well aware of syphilis, but it's always good to revise a bit about the stages, symptoms and signs, how we might diagnose syphilis, treat syphilis, any other management considerations. I'm going to briefly touch on the ASHM consensus statement that was Michael mentioned, and then talk a bit about antimicrobial resistance as well. So I've got some semi-graphic photos on the next slide. They're not genitals, but I'm just warning you. So the stages of syphilis, as I'm sure people are quite well aware. So the primary syphilis, the chancre that typically appears somewhere between 10 and 90 days after first infection. And really, it's an average of about 3 weeks. It can appear sort of anywhere where syphilis has been in touch with the body. So it's sometimes on the genitals, but it can also absolutely be hidden at the back of the throat, underneath the tongue. It can be inside the vagina, on the cervix. It can be inside the rectum. And so people may not notice, they may never see that they get a primary chancre. And really, it will disappear after a couple of days to a couple of weeks. And so people may sort of just wait, and they may go, oh, I'll see how it goes, or see if it resolves by itself, because it will resolve by itself. But really, we're trying to encourage people to get tested, get seen during that time, so that they can get a diagnosis at the point. As I said, it will resolve by itself, and then some people then get secondary syphilis manifestations, and so you can see that rash on the right. Typically this sort of maculopapular, reddish, sort of coppery covered rash that typically affects the hands and the feet as well. But it can be really subtle, it can be really variable, and it can cause it can look like a lot of different things, even just sort of a viral rash, even sort of drug eruptions. And so I'd encourage people that if they're seeing weird and wonderful presentations, if they've got patients with rashes, then think about syphilis as a possible cause of those rashes. It's very important that people, like, you don't assume that people, people's heterosexuality, you don't assume their sex lives, that you consider these syphilis as a diagnosis for people. During secondary syphilis is when you can also get lots of other manifestations. So you can get lots of other organs involved. And the one we get really worried about, of course, is the brain. You can get neurological manifestations. People can have strokes and seizures. You can get the eyes involved. People can go blind. The ears can become involved and people can go deaf and get continuous tinnitus. Can affect the liver, can affect the bones. All sorts of different organs can be affected by secondary syphilis. And so if you've got these weird and wonderful presentations, please consider it. You do need to get people's consent to test for syphilis, but it's as simple as saying to the person that you're going to think outside the box. You're going to order some extra tests like syphilis and HIV just to be sure. And I've never had somebody say to me, no, don't test for syphilis. They absolutely appreciate you doing a more thorough job. You can also then get latent syphilis where people don't have symptoms, and that can be quite tricky to diagnose and really is only picked up on screening on sort of blood testing. And so we encourage people to have regular syphilis tests because they may not have noticed this chancre, it may not have appeared for them, or it may have been in a spot that wasn't visible. They may not notice this rash, it may not be as bad as or as sort of overt as the rash that's visible. And so we encourage people to get regular syphilis tests. Many years, sort of 10 to 30 years down the track after infections, people can then get the tertiary manifestations. So they're the typical kind of, again, neurological manifestations, so the old sort of general paresis of the insane kind of presentation. But really, any sort of neurological presentations could be syphilis. And of course, cardiovascular presentations with dilated heart valves and aortic aneurysms. But they are quite a late sign, and we don't typically see them nearly as much these days, but there's still a possibility. If you skip to the next slide. So how are we going to diagnose syphilis? If you see a sore, please swab it, and please check which swab that you need to be taking for your lab to do a syphilis PCR. They can't do it on a standard culture swab. They often can't do it on a standard sort of chlamydia gonorrhea swab. It has to be specifically the swab that they can do the syphilis PCR on, and you have to specifically ask for syphilis PCR to be done. It can't be cultured on sort of standard medium. You can't sort of send it off to the lab for a syphilis culture. And so really you have to be very specific about what you're going to swab. If you see anything that looks a bit like herpes, swab that also for syphilis. They can absolutely look like each other, even though the chancres are usually kind of are usually singular, solitary, and painless. They can absolutely be multiple. You can absolutely have painful chancres. They are not as sort of, there's lots of atypical presentations around syphilis sores. So please consider anything that looks like herpes, also swab it for syphilis. The blood test that then gets done, remember that during primary syphilis and very early after exposure, the syphilis test on the blood may be negative. It takes time for the body's immune system to develop those antibodies to the syphilis and to be detected on blood. And so you might want to consider repeating blood tests a couple of weeks later to see if there's been an exposure to syphilis or to see if that was the cause. Just note that during secondary syphilis, that is a very reliable time, that if you see a rash and you do a syphilis test, it is a very reliable tool to say yes or no, is that rash your syphilis? If you've got a negative syphilis test during a rash, it is definitely not secondary. You can then, so what happens with syphilis blood tests is that they form a serological scar. So essentially the body's immune system has seen the syphilis, it's developed antibodies to those syphilis organisms, and that will be present for the rest of somebody's life, the vast majority of the time. And so those antibodies will always be detected. So we then use this thing called an RPR, which is also antibodies, but it tends to go up and down depending on the stage of syphilis. And so it also goes down after syphilis treatment. And if people get reinfected, then it goes up again after their reinfection. And so having regular blood tests after initial infection and initial treatment is very important to see that those blood tests, that RPR does come down, and then to monitor if they ever get re-exposed and they ever catch syphilis again, to see that it's gone back up again. They're really important. And so we always encourage people anytime they, if they've first experience of syphilis, particularly young people, particularly heterosexuals, they're not used to getting STI tests nearly as much. But I always encourage them, if they do get syphilis, then they should really be having at least yearly blood tests just to check that RPR going forward, particularly women with sort of pregnancy issues. You don't want to sort of have a query or a question 10 years down the track and you haven't got blood tests in the between. It makes interpretation very tricky. I'd also encourage you, if you do get a syphilis result and you're not sure what to make of it, please call for advice. The interpretation can be really tricky and really uncertain. And it often requires a lot of detective work to work out, has there been previous tests? What were they, previous treatments? You can call Adelaide Sexual Health Centre, you can call CDCB. People will try and find other tests. There's ways to kind of help with interpretation. Please don't sort of, if you're not used to it, if you're not familiar with how to interpret syphilis tests, then please seek advice. So the management, so management is generally penicillin. We really like penicillin injections. It's a direct observed therapy. We know the person has had it. We can be sure that they're going to have the appropriate treatment. If it's early syphilis, primary, secondary, or early latent, is in less than 2 years old, they just need a one-off dose. But if it's latent syphilis is in more than 2 years old, or we're not really sure, then they need those 3 doses. If you are a community prescriber, please be aware that there is off and on, and there is currently a big shortage of the benzathine, the long-acting form of the penicillin. And when I've had a number of cases where prescribers have written a script and the person's taken it to the pharmacy, but they've been given benzyl penicillin, the short-acting IV therapy. And they've received the wrong kind of penicillin, and they have not received appropriate treatment, and effectively they've still got an ongoing syphilis infection. And without somebody kind of picking it up, nobody would have ever really known that they hadn't properly been treated, and they would have just gone along their merry way. But really, you need to make sure that you're giving the right kind of penicillin. At the moment, that seems to be quite hard in community pharmacies. And so please call, the hospital or Adelaide Sexual Health Centre to discuss your patient getting the benzathine penicillin, where we know that it's definitely the right kind, the right form of it. So we want the benzathine penicillin, not the benzyl penicillin. So in terms of alternative treatment options, doxycycline is an alternative option. We don't like it as much. The evidence seems to be quite good about its effectiveness, but it's not a direct observed therapy. You need to take it twice a day for at least 2 weeks, sometimes for 4 weeks. And I don't know about anybody else, but even I would sort of struggle to kind of, take twice a day tablets when I'm not used to it. And so it's a less preferred option for that reason. But yeah, doxycycline is a possible alternative treatment. I won't go through this too much because Danae's got some slides on it as well, but partner notification is really important to get people's partners tested and treated so that the syphilis doesn't go back and forth amongst them, and you sort of get it all cleared up. As I mentioned, follow-up blood testing is really important after treatment to ensure that that RPR, that blood test, does come back down, and that you know what it then falls down to at its lowest level, so that you can then use that to see if it's gone up again for a new infection. Testing for other STIs, obviously every 3 months, ongoing for follow-up. Chlamydia, gonorrhea and HIV tests. Consider the vaccinations that are available, and consider PrEP, whether the person needs PrEP. So the ASHM consensus statement that was released in October 2023, it's a great document, and I'd encourage you to read it if you have any interest in it. But it sets out the data that Michael had described before, and although it didn't have the real world data at the time, really the priority in the ASHM consensus statement is for the prevention of syphilis. So that does work for chlamydia as well. It's syphilis that really has these kind of complications that we want to prevent. Because the evidence is with gay, bisexual, and men who have sex with men and transgender women, that's what the ASHM consensus statement uses. The Carlin guideline that we've written expands that to transgender people, acknowledging that we don't have any evidence. Oh, thanks, Belle. Acknowledging that we don't have any evidence for people who are assigned female at birth, but that there is probably benefit to people as well. So that population of gay, bisexual men and transgender women, and then it's considering the sexual network that people are in as to their likelihood of getting syphilis in the future. So if people have had syphilis in the last year, or they've had 2 or more other bacterial infections like chlamydia or gonorrhea in the last year, or they have partners who have a penis and have a uterus because of the risk of congenital syphilis, or they are attending more higher risk events, so things like sex parties, chemsex, group sex, travel sex, sex on premises venues, because attendance with events like that has a higher risk of acquiring syphilis. And so one of, or multiple of those factors really is the recommendations that ASHM has provided for considering discussing Doxy-PEP with this person. And it's because those risks or those sort of behaviors have high increase of acquiring syphilis in the future. And so we want to really, it's a discussion or a debate between do we narrow down the criteria and sort of identify the people who are most at risk of getting syphilis, or do we expand the criteria and sort of avert as many infections as possible? And it's something that we all sort of think about and we all kind of discuss amongst our clinics. So antimicrobial resistance is a big concern. There's been a number of discussions and papers that have written about the use of Doxy-PEP and the concern about antimicrobial resistance. It's being monitored quite carefully through multiple studies around the world. Obviously, there's concern about the impact on syphilis and chlamydia. With both of those bacteria, there's no evidence that Doxy-PEP induces or increases the rate of doxycycline resistance. There's not been any evidence of syphilis developing doxycycline resistance. There's been a number of studies of low dose exposure and there's no inducement of resistance mutations. Similarly, with chlamydia that affects humans, there's no evidence of doxycycline resistance in the years that it's been used. That is in contrast to gonorrhea, where our baseline resistance in Australia is somewhere between sort of 30 and 45% of gonorrhea is already resistant to doxycycline. And we don't use doxycycline for gonorrhea treatment for that exact reason. There is concern that using Doxy-PEP and exposure of gonorrhea organisms to doxycycline and even, to doxycycline will increase the resistance to other antibiotics that we do use, like cefixime, which is used in other countries, or ceftriaxone. It's really an area that we're watching quite carefully. And then, of course, when you give somebody doxycycline, it's not only going to target the syphilis and the chlamydia, but it's also going to affect every other bacteria that's in your body, including in your throat, in your gut, on your skin. And so there's concern about whether organisms that naturally live on us and are part of our healthy microbiome are going to be impacted by doxycycline. The concern is that not only will those organisms develop resistance, but then they can transmit and move that resistance to other organisms, such as gonorrhea. And that can make gonorrhea more difficult to treat. It can make other bacterial infections more difficult to treat because we remove those treatment options from future options. But really, it's a kind of a risk versus benefit situation in that we have this intervention that we know will reduce syphilis and chlamydia by 70%. And we've seen the sort of the increasing rates of syphilis in community. And so there's significant benefit of Doxy-PEP for the people that we are recommending it for. versus we have risk of antimicrobial resistance, which we don't really know and can't really quantify. It's important to consider the context of this, in that the vast majority of antibiotics used around the world is in animal husbandry and animal farming, and then instead, we're not really concerned about that nearly as much as we perhaps should be, whereas we have this intervention of Doxy-PEP where we know that it will significantly reduce syphilis and chlamydia rates, and we're using it only in a small part of the population, a small subsection of the population, where it's exceedingly beneficial for them. And so it is a kind of a risk benefit. And for some people, they don't want to use Doxy-PEP because of the concerns about antimicrobial resistance, and that is perfectly fine and perfectly acceptable. But it is important discussions to have with people about those options and ensure that they are aware as they go forward with using Doxy-PEP. I think that was all I had to talk about.
Thanks, Tim. That was fantastic. And now handing over to Danae.
Thank you very much, Skye. If you can go to the next slide, thanks. I'm going to talk about some practical aspects of prescribing. So what you actually write on your script and how you tell the patients to take their Doxy-PEP. So the recommended dosage and frequency is 200 milligrams taken as a single dose, preferably as soon as possible after condomless sex, so within the first 24 hours, but up to 72 hours after intercourse. The recommendations here in Australia are around a maximum of 200 milligrams every 72 hours. Next slide, thanks. So what you write on your script, we're prescribing the 100 milligram tablets of doxycycline, and you'd write for the 2 tablets orally within 24 hours, but up to 72 hours with a maximum of 200 per 72 hours. I'm going to go through a little bit more about adverse effects and drug interactions a little bit later, but be mindful of allergy to tetracyclines. It's contraindicated if someone has systemic lupus, as it may exacerbate lupus. Definitely not to prescribe it with oral retinoids, as well as some psoriasis medications. We'll talk a little bit about use in pregnancy and breastfeeding a little bit later. Thanks. Oh, back one, Skye, thanks. So in terms of the quantity, so how much do you prescribe when you see the patient initially? Essentially, in the studies, the median amount of tablets that were used per month were around 10. And it's estimated that you probably want to review someone within 3 to 6 months, depending on their sexual activity. So the initial prescription most of the time will be around 60 tablets. So that's enough for 30 doses. Ensuring that the patient doesn't have it sitting in their cupboard for years, and there's a motivation to come back for STI testing, but also to review how they're going with it, how often they're using it, and also because we've got a lot of data and a lot of research that's going on at the moment, particularly around antimicrobial resistance, so in case guidelines change as well. So you want to estimate how often the patient expects they're going to be using it. Usually the advice is not more than once every 3 days, so approximately a maximum of twice per week. Now, if you've got someone on a healthcare card, the only unrestricted PBS prescribing is for 7 tablets with 1 repeat. It is a fairly cheap antibiotic for private scripts, so there's really much of a muchness between doing a private script for, you can do 14, 21 or 28 tablets plus the number of repeats that you would like. But if someone's on a healthcare card or closing the gap, you may wish to do the 7 tablets with 1 repeat. It's a fairly limited quantity, but it might work out cheaper. Next slide. Thank you, Skye. I suppose the other caveat in terms of talking to patients about how to take it is that it is, as Tim mentioned, syphilis can be close physical contact, including oral sex. So it's important that it's after having condomless sex, which may be oral, anal, or vaginal, or that really close physical contact, and not to take it more than once every 3 days. So there are a few little nice graphics that I like to show to patients. So Ending HIV, which is the AIDS Council of New South Wales, has a lovely little graphic. And look, some clinicians will advise patients if they're quite sexually active over the weekend, if they're having sex on Friday, Saturday or Sunday, they might want to choose to take their tablet on the Monday morning. So that will cover them for the previous 72 hours. If you've got someone who's maybe only having sex on Saturday and not on Sunday, I wouldn't necessarily tell them to wait till Monday. We'll have higher drug levels when the organisms are multiplying if you take it in the first 24 hours. And the CDC American guidelines specifically do talk about the ideal time frame in terms of drug levels is probably within first 24 hours, but it depends on your patient's sort of sexual activity and their sexual practices and when sex happens for them to work out what is the best for their particular circumstances. Thanks, Guy. So look, as mentioned by Michael, it's a really safe and well-tolerated medication, and discontinuation rates when it's used long-term is very low. We've used it a lot and we've got a lot of experience, particularly in acne, rosacea, malarial prophylaxis as well. In terms of the common side effects, we're particularly looking at nausea, vomiting, diarrhea, and generally GI side effects. So epigastric burning is something that can be problematic as well, and I'll talk a little bit more about that in a moment. Sun sensitivity, depending on how much they're taking, how frequently they're taking, may be an issue, so they need to be warned about this. Less frequently you can get sort of stomatitis and rash or fungal overgrowths, and rarely you can get severe esophageal ulceration. So I think all of us over the years, I've had one patient who was on Doxy for treating of chlamydia, who took it at 3 o'clock in the morning after a night shift, went straight to bed and ended up in the emergency department with severe epigastric pain by the morning. So it's really important, the advice around how to take it, which I'm going to cover in a moment. Benign intracranial hypertension is a sort of rarer side effect, which I'll talk about in a moment, related to drug interactions. It's mindful that there is some guidance around caution in liver disease, but it's a non-hepatic, non-renally cleared drug, so it's cleared through intestinal excretion. So it generally does not require a dose reduction or monitoring in renal or hepatic disease. If it's severe liver disease where they're under a liver specialist, I would probably discuss it with a liver specialist who may recommend a little bit more monitoring. I think there have been very limited case reports of transaminase rises, or I think there was one case of liver failure in someone who had cirrhosis. So very rarely is that an issue. Thanks, Guy. So the really important things that probably the main target group is guys that are on their HIV PrEP. It is safe to take with their HIV PrEP, so at the same time they can take the two medications together. If they're living with HIV, there are no interactions with antiretrovirals, and for those who are trans and gender diverse, there are no interactions with any gender affirming hormone therapies, so there's no timing or dose adjustments that are required. You do need to be careful because absorption of doxycycline can be affected, particularly reduced by antacids, iron, calcium, zinc, and fibre supplements as well. And it's important to separate these by at least 2 hours from your doxycycline. There are interactions with warfarin, so more frequent INR monitoring is required, and certainly anticonvulsants can reduce the drug levels of doxycycline and reduce their effectiveness as well. Can interfere with the effectiveness of penicillin and some of the other antibiotics also, and be mindful not to prescribe it with oral retinoids. So advice to patients is really important. Usually the pharmacist will do this, but I also cover it with patients as well. Reinforcement's really important. The number one thing is to take it with food. They do say you can do it with milk also, but to reduce the gastrointestinal symptoms such as nausea. It's important that they take it whilst they're upright and do not lie down for guidance ranges from half an hour to an hour after taking their tablets. The volume of water or liquid is designed so that it doesn't get stuck in the throat, so that reduces the risk of esophagitis. Again, avoiding antacids, iron, calcium, zinc, multivitamins for 2 hours, within 2 hours of your tetracycline, and telling them to be a bit sun smart and apply sunscreen when they're going out in the sun to avoid sunburn. Thanks. Now, in terms of assessment and testing, at baseline, when you first see them, you just want to make sure that there are no STIs present. The population that this is appropriate for, we know in the studies had sort of high rates of STIs at baseline, and we're looking for people that are in sexual networks where there are a lot of STIs. So you would want to do your STI and bloodborne virus screening at baseline. You can still do your script on the day. Use your Australian STI guidelines, but usually for our whatever site of the body is exposed, you would do a, say for a 3-site screen, for example, for men who have sex with men. You want to also do your baseline HIV, syphilis and hepatitis testing also. Assess their risk for HIV and offer HIV pre-exposure prophylaxis if there's an identified risk. Check to make sure they're up to date with their vaccinations, such as Mpox, which is available through Shine and also Adelaide Sexual Health Centre, making sure they're up to date on their hepatitis A and B and HPV vaccinations as well. And you will cover your patient education about how to take it as well. Next slide, thank you, Sky. In terms of ongoing screening, sort of the recommended interval for these clients, obviously if someone's on HIV PrEP, they're going to be seeing you 3 monthly anyway. For those clients who are anticipating that they're going to be taking their Doxy-PEP less frequently, they may be going, for example, on a holiday or maybe going interstate to have a party weekend. They may anticipate that they're just going to use it a few times. You may plan only to see them every 6 months. Certainly it's recommended not to leave it more than 6 months. You're wanting to be testing for STIs and also bloodborne viruses in this population group. So I would usually be guided by the Australian STI guidelines. In terms of additional monitoring, look, obviously if they're on PrEP, you'll be doing your PrEP monitoring. If they're not, there's no additional monitoring required in terms of kidney or liver monitoring when they're on doxycycline. The big question is around interpreting STI and syphilis serology, and we're still being guided in this space. There have been a few case reports of possibly RPRs being slower to rise. And certainly if you've got someone who is coming to see you that's on Doxy and is a contact of syphilis, you would still offer empirical treatment. You'd still do your RPR testing because we don't know yet what the impact is on things like RPR. So you would do the other STIs, chlamydia, gonorrhea, etc. You would test them as you would normally. In terms of the duration of review, as I said, you'd be guided by the patients, but usually every 3 to 6 months. Thank you, Sky. That's it.
Thanks, Danae. That was fantastic. Now I'm afraid you're going to hear from me. In my role as social marketing community legacy lead, I do obviously represent and advocate for community within my role. And I'm going to talk a little bit about how clinicians can advocate for community and their patients. I guess it's just a little bit of an overview. Stigma and discrimination towards LGBTIQA plus people has long been an area of significant concern. And continues to be linked with poorer health outcomes. Many LGBTIQA plus people feel uncomfortable accessing mainstream healthcare due to fear of poor treatment by some mainstream healthcare providers. Research on physician attitudes reveals levels of homophobia and heterosexual bias. Not all physicians, of course, but some. Including reluctance to treat people or negative comments during the treatment of LGBTIQA plus people. And also there's a lack of understanding, I suppose, about the lifestyle and the considerations that sometimes need to be paid for queer people. Just like PrEP, many participants in studies have reported that Doxy-PEP has had a positive impact on their mental health and their quality of life in terms of having peace of mind. And it's a relief from worry over contracting or transmitting STIs. And it's an increased sense of control over transmission and an increase in support for their own sex, their sex partners and community health in general. Now, how to discuss Doxy-PEP with patients. if you're able, have a really open, judgment-free discussion with your patients regarding their sexual health. Not every LGBTIQA plus person is a sexual health expert, so you may need to do some educating. The easiest way, I suppose, is to link them to some of the really great things that are available for them, including the ASHM website with the consensus statement that was discussed earlier. And also New South Wales Health have a really great Doxy-PEP decision aid for consumers. If you're not happy, if you're not comfortable, should I say, having this discussion with your patients, you can refer to services like Shine SA, where they may be able to speak to someone like Danae, or Adelaide's Sexual Health Centre, where they may be able to speak to someone like Tim, who will be able to discuss current and future sexual health needs in an open, non-judgmental way that will give your patient peace of mind and the ability to choose what's right for them. At the end of the day, when working with community, it's about really reducing stigma and discrimination and making sure that community are treated in a really respectful, really open way. All right, we will call it there, but thank you everyone for attending this forum. Thank you to Michael, Tim and Danae for your wonderful presentations. And hopefully we will see you soon for some updates on Doxy-PEP and hopefully how we're going to see it really positively affect the epidemiology in South Australia, well, not just South Australia, but specifically in South Australia for us. All right, thank you everyone. And some of you we may see for the community forum at 6 o'clock, but otherwise thank you so much for spending the last hour of your day with us. Thank you all.